One thing that drives me absolutely fucking insane is when I hear people say that sepsis is when the infection gets into the bloodstream. This is not correct. And yeah, the layperson says that, whatever, but I've heard more than one doctor say this before, which is really alarming. Septic shock is not when the infection gets into the bloodstream. When anyone gets sick or injured, the body responds to this insult with inflammation. The inflammatory process vasodilates to send more blood to the site of the insult, and it delivers white blood cells, macrophages, and other immune stuff to the scene of the crime to fix things up. That's why if your patient has a festering wound on their foot, it's going to be inflamed and hot to the touch. Sepsis is an exaggerated inflammatory response to an infectious source. Let's say that the patient has pneumonia or pancreatitis, or let's even say regular old flu. The body's going to use the inflammatory response to fend off the insult, but when the patient becomes septic, the body is like, holy fuck, and then completely overreacts to the infectious source. This usually happens because the infection gets worse. Duh. However, some people get septic more easily than others, and they aren't sure why. They think it might be a genetic factor. This explains why the 98-year-old carcass from the nursing home will get a raging pneumonia and then get better after a single course of antibiotics, but the healthy 23-year-old ends up on ECMO with a freak case of flu. Anyway, in septic shock, the body activates a fuckload of inflammatory mediators like cytokines, histamine, prostaglandins to fend off the infection. But it's too much. These will all cause vasodilation, huge vasodilation. And when that happens, the size of the vascular container expands massively. Even though the patient may have a perfectly normal blood volume, the container is too fucking big for it. This is called distributive shock. The blood doesn't fill up the vascular container, and that screws up flow. The blood flow gets sluggish and doesn't offload oxygen to the tissue, so they get starved for oxygen, and that fucks up the whole Krebs cycle thing. And then the metabolism gets shifted from aerobic to anaerobic, which is bad, and the byproduct of anaerobic metabolism is lactic acid. That's called stagnant hypoxia, which is always a test question on the FPC or CCPC exam. Also, the shock state, the lactic acid, and the inflammatory mediators have a suppressant effect on the heart, which makes things even worse. Years ago, infection plus bumped lactate equaled sepsis. Not anymore. We were missing the boat on septic patients because we were too focused on lactate, which may not be bumped, especially in early sepsis. Also, many other things than sepsis can cause the lactate to get elevated. Then, they made it Sears criteria plus infectious source indicates sepsis. Then they came out with QSOFA, and they wrote a whole lot of journal articles about it and rolled it out, but with the caveat that this doesn't predict sepsis, rather it predicts mortality in the patient who may be septic. Clear as mud. When should you suspect sepsis? Well, does the patient have an infection, or do you suspect an infection? Then, do the vital signs indicate that there is a systemic response to that infection? Like tachycardia, tachypnea. If there's hypotension, that's pretty much a ding, 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 you have sepsis thing. We now have a very low threshold for identifying sepsis and getting the ball rolling on treating it. So what do you do to treat the patient who is in septic shock? 1. Draw cultures. 2. Give antibiotics after you draw cultures. 3. IV fluids. These patients are going to need IV fluids. No, you don't want to do the 1995 method of 72 liters of isotonic crystalloid, but don't be afraid to give them a liter or two of normal saline or lactated ringers. There is a massive debate among nerds about which fluid is best, normal saline or lactated ringers. Many paramedic school instructors like to say that giving normal saline is like giving battery acid, and that lactated ringers is so much more balanced. I can debate this with your instructor until the cows come home, but after reading peer-reviewed article after article after article, it probably doesn't fucking matter. LR is still an acidic solution. 4. Give pressors. Pressors should actually be started earlier than once thought. You need to shrink the vascular container. Norepinephrine is the pressor of choice. It has an alpha effect, which vasoconstricts, but it also has a little bit of beta property that will help with flow from the heart. It's a drip. Many EMS programs don't have Levofed, so feel free to use push-dose epinephrine or an epi drip. But Levo, if you have it, It's the GOAT in sepsis. That often doesn't do the trick enough though, so then you have to add a second pressor, usually epi, but some places go vasopressin. Whatever your protocols dictate is fine, it probably doesn't matter. Then they'll add a third if needed, and then sometimes they'll add phenylephrine. Phenylephrine is a pure alpha that clamps the shit down out of the peripheral vasculature, which again shrinks the vascular container and helps to ameliorate distributive shock. Over time, if they're on a lot of pressors and they're clamped down, they may get ischemic digits and limbs. And that's why your septic patient may have to get an amputation if their peripheral part of the body gets super ischemic and damaged. But in transport, you want to deliver your patient alive. Don't hold off on giving a pressor because you're worried about limb ischemia. You're not going to cause it in your role as a paramedic or transport nurse. You don't want to be the person who delivers a febrile patient to the hospital with a pressure of 42/20 and says, "I was worried about limb ischemia, so I didn't treat the hypotension." And that is my basic rundown on sepsis.